Hi.
Hi guys, so this is Dr. Mirsch. I am one of the crew for the Probing the Literature as part of ACEP and SAEM's Probing the Literature. This week we'll be discussing vascular ultrasound, which is going to include both peripheral IV as well as a systematic review on DVT. So I'm not going to delay you with any more of my theatrics. I'm going to let the authors of this paper, Drs. Melissa McCarthy, as well as Dr. Keith Boniface, to take over. Thank you very much.
Great, thanks. Hi, I'm Keith Boniface. I'm the Director of Emergency Ultrasound at GW, and my counterpart is Dr. Melissa McCarthy, who is a professor of emergency medicine and public health here at GW as well. And we'd love to talk to you tonight about this paper, ultrasound versus landmark for peripheral IV cannulation on RCT. Can we have the next slide, Melissa?
Okay.
Yeah. So this is something that we all do as part of our practice, and this was a few years back now, but the sort of one of the reasons that we undertook this study was because we identified some gaps in the literature that we reviewed looking at ultrasound versus landmark for guidance of ultrasound guided vascular access. And those gaps in the literature are always a good place to start when you're looking to launch a research project. And when we look through the literature, the prior studies that we saw had relatively small sample sizes, sort of 35 to 60 participants. The patient populations were heterogeneous, and there were some varying definitions of difficult vascular access that may or may not kind of apply to everyone's shop. And they also had some significant variation in operator experience. How many of these ultrasound guided IVs had the people who were actually placing the catheters had in the past? And so we decided that this was ripe for exploring. Melissa, can we get the next one? Another reason we undertook this study was because our setting was right at the time. We had been training our emergency department technicians in ultrasound guided IV placement since 2008. And so as a condition of employment, these techs are trained to perform ultrasound guided IVs during their first quarter of employment. And then they have to perform 10 successful ultrasound guided IVs in the proctored by a super user. And so with our ongoing program, we had a well-trained and experienced cadre of folks who were doing this as part of their daily job for a significant period of time, for years before we did the study, which we'll talk about in a little bit, because it does end up being a potential limitation to the external validity of this study. And we'd also performed some other research projects kind of leading up to this, looking at the training process of our techs, looking at the patient experience, and then the impact of this ultrasound guided IV program by our techs on our central line placement rate, which really cratered over the time of this program. And we started with a group of 36 ED technicians. And as part of the data, we asked them how many years they had experience placing these lines, and how many of these lines were placed in a typical 12-hour shift. And just a word about our nurses. Our nurses were not a part of this ultrasound IV at the time. More and more of our nurses are doing this currently, but at the time of this study, our nurses didn't really do ultrasound guided IV, oddly enough. Next slide, please. So we wanted to include all patients in our study, not just some subset of difficult IV access patients by a variety of definitions, but we wanted you, the author, or the readers of the study, to be able to apply the same definitions that we had to your patients at the bedside to make it clear the generalizability of this to your patient population. So we used a subjective and an objective criteria. The subjective was basically, does the tech think this is going to be an easy line, using a landmark approach? And then objectively factoring in there was whether after the application of a tourniquet, if you could see or palpate a vein in above the wrist in either arm. And so easy access in this study was the tech says it's going to be easy, and that's it. Difficult is the tech could not see or palpate a vessel, and then moderately difficult was the tech thinks it's going to be a difficult line, but they could see or palpate at least one vein. And so that's the definition that we used to when we get into the randomization across groups that we'll get into in a few moments. Next slide, please. And so the overall purpose of this study was to evaluate whether ultrasound guidance or landmark was superior among patients with moderately difficult, or easy IV access using a single operator technique. And so our primary outcome was the success rate of the first attempt. And then, as we'll get into in a second, then all those who failed the first attempt got randomized into ultrasound versus landmark. And we also evaluated the success rate of that second attempt. And then we followed a number of secondary outcomes like complication rate, the time of the procedure, and the patient-reported pain. And the main independent variables in this study were difficulty of IV access and then the procedure method, either ultrasound versus landmark.
So obviously we conducted a randomized controlled trial, and one of the interesting things about our randomization process was we decided that we would randomize within each technician, as well as by whether the patient was classified as easy, moderately difficult, or difficult IV access. So what this meant that was, for each tech, and every 6 patients within each easy access group that they said moderately difficult access group or difficult access group, there was an equal distribution of their patients randomized to landmark or ultrasound. And then as Keith also mentioned, we randomized them a second time. So essentially, if it failed the first time. And so what this allowed us to do was, now we kind of had a very objective definition. These were patients that were difficult because they failed on the first attempt. And so then again, if they got then when they were randomized the second time, would we see the same results as the first attempt? And so that was kind of a little unique aspect to the study. We did an intention to treat analysis, which means, do the patients get, are their outcomes analyzed according to the allocation scheme? And in our case, you'll see in the next slides, it really wasn't a big issue at all, because the vast majority of patients who got randomized to ultrasound got ultrasound, and vice versa with landmark. And then another piece that we looked at in the study was this interaction effect. I think it's also another reason why we didn't try to just focus on difficult access patients, but rather we looked at the whole spectrum of patients in the ED, because we were hypothesizing actually that maybe the IV placement method might vary, the success rate of the IV placement might vary depending on how difficult access was with the patient. And also I should mention that pretty much every patient that required a peripheral IV line was involved in the study, except for if they put the IV in the hand. We also excluded triage level 1 patients and acuity level 2 if we deemed it was going to take a lot longer, it was unsafe to delay the peripheral placement. So this is a flow chart just to show you we screened 1,662 patients for the study, and almost 1,200 were randomized. You can see we had more easy access. Almost 600 of the patients were considered easy access patients, 400 somewhat difficult, meaning we can see at least one vein, and then almost 200 where the tech said, I can't even see or palpate one vein. And then you can see also that of the people that got randomized to ultrasound or landmark, almost everybody got the treatment that was intended. We only have 2 in the difficult access group and 5 in the easy access group. And then it shows you again on the second randomization, the 227, the first attempt failed, and 197 of them were randomized again. We had a small number that were not randomized again, either because patient refused the randomization, or we just botched it logistically. This slide just shows you that randomization was successful. You always want to just make sure that your randomization worked. Not only do we kind of have a relatively equal number of patients within each access group getting ultrasound and landmark, but also if you look at all the covariates and you look at their distribution within each access group, an equal number proportion are having ultrasound, or the age distribution is not different between the difficult access group by a placement method. So it's a good check on your randomization scheme. This slide, I think this is Keith's taking over again. Right, Keith?
Yeah, sure. This slide is a busy table. I don't see that I have my annotation ability to sort of circle things, so I'll just sort of. There's really 5 main takeaways from this first slide, from this sort of table 2. The first is the initial success rate. So if you look at first attempt, the initial success rate for difficult access was 81.6% with ultrasound and 35.1% with landmark. And the confidence intervals went from 1.7 to 3.1. For moderately difficult, it was 81.2 with ultrasound percent success rate versus 71% success rate with landmark, which had a lower risk ratio. Also had a significant confidence intervals just above 1. And then, interestingly enough, in the easy access group, people who the techs felt right from the get-go they were going to be able to get a line in this person, landmark was actually easier than ultrasound, and that was statistically significant as well. So one big take home: if you see a vein and you can palpate a vein, you think you're going to be able to get an IV in there, don't bother bringing the ultrasound machine to the bedside. Everyone else, bring the ultrasound machine to the bedside. As far as complications, is this next group, and it's kind of broken down by types of complications, and they were pretty much few and far between, and no significant differences were found between ultrasound and landmark. The duration, which is this next line after complications, was longer with ultrasound. It took almost twice as long across all groups. Anywhere from 2.5 to 3.5 minutes, it seems, total, as opposed to half that for landmark. So that's something you have to plan on if you're using ultrasound. And this is from tourniquet time to flush. So this is this does not include bringing the ultrasound machine to the room or getting your machine sterile. The next thing is the second attempt, like Dr. McCarthy was talking about. We wanted to make sure that after we identified a subset of patients who were truly difficult because they failed on the first round, we would randomize them again and make sure that the same kind of direction of impact and magnitude of impact held, and it did. It was fairly similar to the first round, 84% to 25%, and again with the easy patients, the landmark performed much better. And then last thing is the pain rating. The pain rating was a little bit more with ultrasound, but not statistically significant, and doubtful if it was clinically significant. Okay, next slide. This is basically similar information on a whisker plot. basically the first attempts are shown in black, and the second attempt, people who failed on the first attempt and were randomized to a second attempt are shown in red. And the red is a longer bar encompassing the 95% confidence interval, because the confidence intervals were wider because there were many fewer on the second attempt than on the first attempt. So the black bars are shorter with tighter confidence intervals. And it just shows the same kind of findings that with easy patients, landmark is favored, and with difficult patients, then ultrasound is favored. It also took a look through our technicians, dividing them by the amount of ultrasound experience they've had, and the same kind of distribution fell out, although with people with less experience, there was not a significant benefit found for that moderately difficult group. But with more experience, people were able to get a performance edge and a performance benefit with using ultrasound in that moderately difficult group. Next slide, please. This is just circling back to that point about operator experience that I alluded to earlier. We had 36 technicians in our department. The vast majority participated in this study, 92%. The range of patients enrolled per technician was anywhere from 9 to 55, with a median of 26. 82% of these techs enrolling reported they had greater than a year of experience placing ultrasound guided lines. So this is a little bit different than your study where you train a group, let them go out in the world for a week or two, and then study their performance. These are a group that were doing this every day in their practice. And then the other thing that's clear, aside from the fact that these folks were pretty experienced, was the fact that this was a pretty complicated, difficult vascular access patient population. They reported that 40% reported that they put greater than 5 of these lines in a typical 12-hour shift, which is, as you can imagine, why we ended up training people how to do this in the first place. Next slide, please. And so take-home messages from this study: ultrasound is superior for difficult and moderately difficult IV access patients. For difficult access, you'll have an additional 48 successes for each 100 difficult access patients. So a number needed to treat of 2.2. It's very, it's a very high yield procedure. Even for the moderately difficult cases, you'll get an additional 10 initial successes for every 100 moderately difficult patients. So that's a number needed to treat of 10.2. And then for the easy access patient, the landmark was superior. So using landmark gave you an additional 11 successes for every 100 easy access patients, for kind of a number needed to harm of 9.3 for using ultrasound. Landmark is superior for procedural duration, almost 2 times as long, and there was no meaningful difference in patient-reported pain. We did look at a couple of other comorbidities, covariates, age, BMI, other conditions that would be expected to kind of correlate with difficult IV access, arm circumference, and none of it was a significant impact, probably because it correlated with our clinical bedside definition of difficult IV access. So those sort of fell out in the analysis.
Okay, so the last slide is just that I think that the study is a really nice example of leveraging the strengths that you have in the resources in a department. You know, like Keith said, the emergency department at GW has a kind of a robust clinical research operations. There's trained ED researchers, assistants who are in there that work on different studies. And so actually there was no funding. We had no funding for this study. It was just all internally done, which is amazing, really, you know, when you think about it. And then the fact that, you know, that there's a very strong ultrasound presence in this emergency department, you know, not just the residents, the you know, the fellows and the faculty, but also the technicians, and now Keith's saying even the nurses. And so we didn't have to, like, we didn't use providers that had just been trained on ultrasound to kind of look at the effectiveness of ultrasound. And then too, you know, Keith and I bring very complementary types of expertise, you know, so the study team, you know, had some, you know, emergency medicine physicians who know a lot about ultrasound. It also had kind of health services research and statisticians to help with the design and conduct of the study. So, you know, it was a nice marriage, because how I describe it. And then we also, I don't know if some of the institutions have REDCap, but that's a, you know, it's an NIH funded free data collection system that's easy to use and really great. So I recommend, if your programs, you know, want to collect clinical data, that's a great resource. And then finally, I just wanted to note that we had a follow-up paper by Dr. Shakui that looked at, you know, as part of the study, we also followed the patients through the end of the ED visit, or if they got admitted into the hospital, to see survivorship status up to 72 hours, because there was some past literature suggesting that ultrasound guided IVs don't stay in place as long, and we did not find that at all. There was no difference in survivorship. So that's it. Thank you.
Well, that's wonderful. Thank you again very much for presenting all this wonderful literature. And just, again, this is such a fantastic prospective study at a single institution that someone can draw up and submit to the IRB. You leveraged your research assistants, you leveraged those, the techs that you were training and already had trained. And then, you know, all these things that you're mentioning. And I'm wondering, even if you had the same data set and you're getting multiple papers out of the same data set. So you got the survivorship paper, you have the low, moderate, high difficulty paper, and then even a infection rate paper or a complication rate paper would be something that I know the literature still needs, and the AIUM and all the safety committee people are all clamoring to try and say, like, you know, low-level disinfection and probe covers and all that jazz. So the more literature we can get for that sort of stuff, the better. I'm going to open up the panel to questions. We have about 5 minutes before we're going to switch over to breakout rooms. So I'm going to open up the floor.
I have a question. First, I wanted to say hi, Keith Boniface.
Hi, Liz Rapolo. Long time no see.
I know, he was my attending your first year, I think, as an attending GW.
Lynn Rapolo saved me as I was lost in the GW ER.
I didn't know about that, but we had fun. Anyway, fantastic study, both of you, and you should be applauded for. It's a sophisticated ultrasound study, and it does have several findings that I think, as you know, we were just talking about with Dan, that you have just a lot of results to share. And one of the things, I don't know if this is because I haven't reviewed the literature on teaching techs how to successfully do ultrasound guided IVs. And I know GW has had just a history of really being able to train their techs. Like, they taught me how to suture and we have a whole sophisticated suturing program. So it doesn't surprise me that your techs are actually trained to do this. So I don't know if that was if that's novel, or if everybody is using techs to do ultrasound guided IVs. You know, at our shop, it's mostly our nurses who are trained. So I was just curious about that. And then if you could just briefly comment on just the logistics, so other people who are listening could repeat a similar study. So a patient came in, you have research assistants. How are you staffing the emergency department? Are these research assistants, are they medical students, or are they people who are recruited from outside? Was it 24-hour thing, or was it medical students who only had like a summer break? I was just curious about how that was all correlated.
Well, I think I'll answer. So we have an undergraduate clinical research class that we teach. And so largely the pool of research assistants are coming from these undergraduate GW students who mostly want to go to medical school eventually. So they take the clinical research class, and then as part of that class, they shadow with a trained research assistants. And then many of them apply to become a research assistant, which is a paid position. And from taking the class and watching them interact all, semester under the trained research assistants, we figure out who's good, who's really good with patients, who's good with the providers. And so when we have a job opening, we just very selectively choose, from that. And the clinical research class is in the fall and the spring. And then in the summer, we have like an internship where we open it up to anybody in the country who wants to just spend the summer working with our research assistants who we already have as an internship. And and there again, we get really high caliber undergrads who want to go to medical school, and they'll spend the summer with us. And sometimes they take a gap year and they become our trained research assistant, and they'll work a whole year for us. So that's how the pool works, and it works. It's a great way,
Wow. Does the department fund that? And then is there a dedicated faculty who runs your program, or do you train it like a super student who ends up being kind of the manager and the scheduler, and then somebody else inherits that role eventually, sort of thing?
Yeah, so the department funds it, and we have a coordinator that kind of oversees that, because we're also coordinating not only the research assistants in the ED, but also with the class that's in all the students that are coming into the ED. So there's a lot of movement, and yeah, so we have somebody. And, so if we have funded projects, then that defrays the cost of what the department pays, because you don't essentially have to hire research assistants even for funded projects. You can just pay into the pool and use them. So that's kind of the way it works.
And then when I come along with an unfunded research project, then I just have to wash Dr. Meltzer's car every once in a while, and he'll give me some hours.
That is fantastic. Thank you for sharing.
So
Yeah.
I'm curious about the techs. So we have paramedics in our ED. Are your techs, is that a separate job category, or I'm not quite sure I understand the training of those folks.
Sure. The techs in our department, a lot of them are paramedics. We have a separate paramedic role in our department where they have some patient flow and medication administration responsibilities, and so this is separate. These really are kind of like a medical assistant role where they're doing EKGs and drawing blood and placing IVs and transporting patients and sitting on our sitting and watching the suicidal patients, and so there's a kind of and the goal is to try and have the nursing staff practice to the top of their license and do patient care and documentation and medication administration. And so these EMTs, and most of them are EMTs, some of them are paramedics, a few of them are people who just go through a patient care technician class to get these skills in the department.
All right, thanks. Yeah, our paramedics kind of do all of that. So I was just curious. And then we have observers we have another job category that's just behavioral observers. And we frequently run out of those, and then our paramedics wind up having to fill that, which is really not ideal.
Yeah, that's a great way to just continuously be doing the top of license at every category of need. So I wish I had something close to that, and I don't. All right, I am going to initiate the breakout rooms. So we have 4 total breakout rooms between me, Lynn, Sandy, and Lindsay. We're going to start assigning people into those rooms. Everyone is going to have about 18 minutes just because we're running over a little bit. And the materials should have been sent to all the leaders. If any leaders want to message me about needing additional materials, feel free to do so. Otherwise, I am going to initiate the breakout rooms. See you in the room.